All right. So welcome everybody for today's webinar, Global Neurosurgery Roundtable, Innovation and Insight from Africa. We are privileged to have Dr. Halinder Mangat, who will going to talk about on the essential care or TBI. But before that, I would like to share with you some rules, housekeeping rules for this series. Next. Sorry, next slide. Yeah, sorry, the slide was not working. All right, thank you. The next slide, yeah. So before we begin, please keep your microphone muted during the presentation to minimize distraction. The host may mute you if needed. Please raise your hand during the Q&A session. If you have any question, once you are called on, please unmute yourself. Remember to mute yourself again after your question has been answered. We are live streaming this webinar on YouTube. If you do not wish to be seen, please be sure your camera is turned off. Leaving your camera on indicate your agreement to be streamed in public. Webinar will be offered on every third Thursday of each month, starting at 8 a.m. in New York time, but also around when New York time goes back to standard time, we'll continue to meet at 10 a.m. here. Your time may be later changed if your locality does not use daylight saving. With that in mind, I would like to introduce to you Dr. Halinder Mangat, who is an associate professor in the Department of Neurology and a neurocritical care specialist with the University of Kansas Health System. He joined Kansas University Medical Center 3 years back after 8 years on the faculty at Weill Cornell Medical College in New York. A dual certified in internal medicine and neurology, Dr. Mangat spent 2 years as a research fellow in a neurochemistry at Karolinska Institute in Stockholm, Sweden, and subsequently completed his fellowship in neurocritical care at Addenbrooke Hospital, Cambridge University of the UK. He also earned a master's degree in public health for developing country from the London School of Hygiene and Tropical Medicine. Dr. Mangat's interests are in global neurotrauma, especially in low and middle income countries. He has worked for nearly a decade in a capacity building program in Tanzania and conducted research in neurotrauma in hostile environment. Please, Dr. Mangat, you are warmly welcome to the platform.
Thank you very much, Romani, for the kind introduction and for hosting me. I hope to leave time at the end for, I think it would be good to have a robust discussion on this topic. So I'll start off a little bit with my non-professional background. My parents are originally from India. I went to university in India, and sort of having lived in different healthcare setups, I aim to try and bring what we learn from different healthcare systems together to see how we can try and make healthcare provision not only more equitable, but also more simple across the board. And this applies not only to LMICs per se, but I would rather say resource-constrained environments. For example, it could be Hawaii, it could be North Dakota, it could be a lot of rural places, even within the United States, that do not have access to, or immediate access at least, to specialized trauma and neurotrauma care. So I'll start off with probably just going over a little bit of epidemiology that I'm quite certain everyone's heard of before. The estimated global burden of head injuries is between 27 to 69 million people per year. And out of these, they break down pretty much into a third in terms of mild, moderate, and severe traumatic brain injury. Currently, we probably underestimate the incidence of mild TBI, and that's just because it does not present immediate consequences as opposed to moderate to severe head injury. Overall, the mortality globally, at least in trial circumstances, is shown to be 25% in severe head trauma in high-income countries and 50 to 55% in low middle-income countries, as the paper was written by Ian Roberts et al., putting together all patients from the CRASH trials. Now, again, this is under, sorry, I don't have slides.
Oh, okay.
Yeah, I just decided to do a talk and listen. So within trial circumstances, the mortality rate is about 55%. So outside of trial circumstances, the mortality rate in resource-constrained environments is significantly higher. In our registry from Dar es Salaam, from Muhimbili Orthopaedic Institute, which is the National Neurosurgical Institute in Tanzania, we've seen the 2-week mortality is about 67%, which reflects more or less the epidemiology and outcomes as in most austere environments, and it's dictated by 2 major factors. The number one is the delay in getting to a tertiary care center, and then the second one is resources, be they predominantly human, actually, because a number of trained neurosurgical specialists are significantly lower in resource-constrained environments compared to high-income countries. So our data showed that even within urban Dar es Salaam, 88% of patients were referred from having gone to another healthcare facility and were subsequently sent from there to the neurosurgical hospital. And that's within urban areas. So that reflects the reality across the world, where 90% of patients will first go to another hospital where trauma systems are not organized. And the typical patient is a young male. Our median age in the Tanzania cohort was about 32 years. And these are breadwinners, earners, contributors to the economy, not to minimize that females also do at that age, but there is culturally a greater pressure to spend, to undergo catastrophic health expenditure in the care of such patients.
And will take, yeah, and here you will measure the depth of insertion.
Thank you. So we have guidelines for the management of moderate severe TBI. However, most of them come from very well-resourced environments, and 90% of the burden of TBI is not in well-resourced environments. So the bigger overarching question is, what can we do? We try on a daily basis as individuals to do better, but as systems, what can we possibly do? Is providing neurosurgery to every patient the answer? Approximately in resource settings, these surgical rates are about 30 to 35%. In less resource circumstances, they go up a little bit to about 40% patients need surgery. In blunt trauma, in penetrating trauma, nearly everybody needs neurosurgical intervention. But can we provide neurosurgical care to everybody? And that's the tricky question, because in current capacity building paradigms, neurotrauma is being taken care of by neurosurgeons, and the emphasis remains on the neurosurgical intervention, though I would argue that's a small section of the patients. So the EPIC studies from run out of Colorado showed just fundamental things. Is in that cohort, overall, about 11% of patients suffered some hypotension at some point. Of the patients who suffered a severe TBI, about the average death rate was 11%, and that's very short term. Those who had no hypotension at any time their death rate was 9.2%. If they had pre-hospital hypotension only, that rate jumped threefold to 27 to 28%. When they had hypotension in the emergency department, that rate jumped up to 45%. Now that's 5 times the death rate of people who did not have hypotension. Those who had hypotension both in the pre-hospital and the emergency room, their death rate was 58%. And that's between 6 and 7 times the mortality. So could we reduce deaths by providing neurosurgical care to that degree? Could we make them 20% of the overall cohort, reduce them 5 times by operating on patients? I don't think so. So should we make sure less patients have hypotension than those who require surgery? Maybe. The death rate is if you had hypoxia only, was 28%. But if somebody had hypoxia and hypotension, that nearly doubled to 44%. So if we put these things together, just by hypoxia and hypotension, the death rate goes up to somewhere between 7 to 8 times compared to people who don't have this exposure. So what does that mean for our patients? Because we know if 80% are being transferred, that these patients are suffering most likely pre-hospital and emergency department hypotension and hypoxia. If we look at healthcare dollars to be spent for every neurosurgical intervention, the cost of one intervention will probably cover the cost of preventing hypotension and hypoxia in hundreds of patients. So about 4 to 5 years ago, there was the Peshawar Declaration, which is recommendations for a framework of health management of neurotrauma at the level of healthcare systems was done by Dr. Tariq Khan from Pakistan and Key Park from Harvard. And that provides a health systems framework of how to organize and what are the key components of neurotrauma care. There's the pre-hospital, the in-hospital, within in-hospital, its emergency department and surgical and then rehabilitation. So what we are proposing to focus on is the in-hospital care, hospital being defined as any facility that receives or provides any care to TBI patients. That may be a neurosurgical center or the vast majority of hospitals that then that first receive TBI patients and then transfer them on to higher care centers. So if we envision, for example, a pyramid of care in terms of complexity, can I share my screen for just a minute? Let's see. There we go. Sorry. So could everybody see this slide?
Yes.
Okay. So if we conceptualize the acute care of, I would say, moderate to severe TBI, because moderate TBI patients are the ones that stand to gain the most. And they usually either get better or they get worse. They don't remain moderate in a way. So if we define, for example, a pyramid of care where the very basic level would be basic critical care and emergency care for all the patients. And the pyramid, you see, it's not a straight line up, it's pyramid, that a lot of patients will benefit from that. And then the next step would be essential TBI specific care, where the care that's provided is the basic critical care plus very specific TBI care. And then we get into more advanced TBI care, which is provided in tertiary centers across the world, where you could consider ICP monitoring and so on. But the question is, how do we split this into different components, and how do we decide what is advanced and what is essential? Now, essential being defined as an equitable provision of care to anybody suffering a TBI anywhere in the world at any time along the whole chain of trauma care. So it should be available to anybody and everybody at all given times, at any place, and along the whole chain of trauma care. So it really goes down into strengthening, in a way, the chain of trauma care. So how do we build this pyramid? And so a lot of this came to light in the COVID pandemic, where at least 50% of people in sub-Saharan Africa who were hospitalized for COVID did not have access to oxygen, and resulted in approximately 500,000 deaths that were entirely preventable. And very interestingly, till COVID, and actually for a couple of years afterwards, the WHO, in its list of essential medications, listed oxygen as an essential medication for perioperative care, but not for critical care. And through lots of work by a group of people led by Tim Baker from Karolinska and Karima Khalid, who's an anesthesiologist in Dar es Salaam, they a work group put together a similar consensus as to what constitutes essential care, essential emergency and critical care. And I think within the last year, the World Health Assembly has passed the ECO resolution, which is a resolution on emergency, critical care, and operative care. And the goals of these are to minimize deaths by improving access to oxygen and basic and essential critical care, which then takes us to what is the fundamental, the lower rung, which is defined as essential emergency and critical care. And the key component of that essential also being it should be available to everybody, everywhere, at all times, without inflicting catastrophic health expenditure. So the two parts of the essential and emergency critical care are, number one is identification of critically ill patients. The second part is providing the essential organ supportive care for these patients. And the third component is that they should have effective coverage. And this will lead to stabilizing patients and increasing survival. It is estimated with modeling that this would save up to 1 million lives per year. So what is essential emergency and critical care? So it is composed of about 40 processes, but which might seem a lot, but it's actually what we do as acute care physicians day in, day out. It's triage of critical care illness, checking a pulse rate, blood pressure, respiratory rate, oxygen saturation, temperature, level of consciousness, either using the Glasgow Coma Scale or there is an alternative AVPU scale. It's awake, verbal, pupils, etc. Do they have abnormal chest sounds? What is the overall condition, especially as voiced as a concern from the healthcare worker or the family member? When is triage conducted? It should be in a very short time span after a patient arrives at a hospital seeking acute care. And we see it during flu season where patients can be lined up in emergency rooms in massive hospitals in the US and cannot be seen up to 8 hours. And if somebody's critically ill, well, that's not going to do them any good. And not only should they be triaged and identified the moment they come in, but at the very least, every 24 hours subsequently. How we regard healthcare workers or patient or guardian family members' concerns and response to them during their stay, during and after surgery or anesthesia, during and after transportation, and following a treatment that's given. And it's broken down essentially into what we do every day. It's the ABCDs, the airway. Are patients in an appropriate recovery position? Do they get suctioning of the secretions? Do they get an oropharyngeal airway? Is their position for breathing optimized? Do they get oxygen? Then are they in shock? Do they need their head? Do they need to be lying flat? Are they bleeding? Do they get IV fluids? Or for general critical care, it would be intramuscular epinephrine for anaphylaxis, peripartal hemorrhage, and so on. And then reduced consciousness level. Do these patients get dextrose? Do they get protection from harm if they were to have a seizure? Do they get anti-seizure medications, treatment for severe hyperthermia, or in neurotrauma, in the case of neurotrauma, is reduced level of consciousness? And other things, if you cannot put an, insertion of an IV cannula, and if you one can't get an intraosseous cannula, stabilizing cervical spine, appropriate antibiotics, analgesics, and it preventing delirium and eventually mobilizing patients. So that's essentially the fundamental thing. And as data has shown us, as much as TBI is thought to be a surgical disease, mere prevention of hypotension and hypoxia in itself can reduce mortality fivefold in these patients. And we tend to focus on tertiary care centers, but a lot of this care should be delivered at district hospitals, perhaps even sub-district hospitals, where patients arrive. And that means greater coverage of provision of oxygen, as well as IV fluids, but also diagnosis, screening of patients to identify them. And so it is an effort from our part then to establish and figure out how to operationalize this pyramidal care. And for this purpose, we are conducting a global survey, a modified Delphi survey amongst TBI healthcare providers. And we have now been able to enlist about 275 specialists from 60 countries and we will perform a Delphi, a modified Delphi survey where the questions will be predetermined, and we are hoping we won't have to go into redefining them as we go along. And the first round of that is very much as to establishing what is the lowest rung of treatment that we should provide, which would be essential emergency and critical care. Identify patients and then provide the essential treatment to them. And then comes, so we know a lot of that already, and it's being implemented in Malawi and Tanzania by the department, by the ministries of health. And, do we need separate pathways for every disease? No, we could leverage that and the eco-resolution by the World Health Association to then define so on top of that, so that's very disease agnostic. And then what can we do that's disease specific, which would be defining what should be the components of essential TBI specific care in the management of patients once they have been provided and continue to be provided essential emergency critical care. And so we have sent out round one, which essentially focuses on the EECC, essential emergency critical care, and the focus of the questions on that are on what we define for TBI patients, the fundamental monitoring, critical care monitoring treatment, and the processes required as far as general critical care is concerned. Round two subsequently will work towards identifying what the current practice of disease-specific care is, and within that, to find commonality between cost-effective measures, and that's where the global representation becomes important to see, can we define low-cost measures that are very TBI specific in improving outcomes across the globe. And so that consensus building would be very important, that we first identify what are commonalities, we identify what's cost effective and feasible, and put together a list of processes that don't have to be necessarily treatment. It's triage, identification and then treatment, and within treatment, it's surgical and medical treatment that should be available to everybody, everywhere, at all times along the chain of trauma care. And we don't know if we need just yet to get into advanced TBI care, because that's already sort of predetermined by guidelines. And so the essential part would have to be something that is pragmatic, but also evidence-based. A very good example would be when we looked at our Tanzania cohort, the use of hypertonic saline or mannitol occurred in about 40% of patients, but more than 55% of patients had pupillary abnormalities. So right there is a huge window for us to act on, where patients their treatments exist and need to be given, but there needs to be recognition, again, in the identification, but also in the administration. So the whole conceptual framework is identifying low-cost treatments that are available, feasible, affordable, and make TBI care equitable. Does that include surgery? I think we're waiting to see. If we can improve mortality and outcomes by minimizing hypotension and hypoxia, that in itself would be a giant leap in numbers. And then, is it just perhaps a ventriculostomy or CSF diversion or some sort or hyperosmotic therapy or sedation? Or do we go in and say, well, everybody should have access to surgery, keeping in mind that may not necessarily, while that is normative and optimal, may not be very pragmatic approach. And how do we then decide this continuum of care and what fits in which intensity of care? I would stop there and open the floor for questions.
All right. Thank you so much, Dr. Mangat, and thank you everybody for listening. I'll take this opportunity for welcoming everybody to feel free to ask any question, or if you have any contribution, please welcome. Just raise your hand and we can point you.
Dr.
Welcome, Professor Kulesh. Yeah.
Hi. Hi, Hal. Hi, everyone who's joined and those who know me and who don't. Hello from Nairobi, Kenya. Hal, thanks for kind of bringing this to attention. The issue that at hand, from what I the issue at hand, I joined a little late, but from my understanding of your very elaborate discussion is, should we as a global community, correct me if I'm wrong, and feel free to stop me if you think I'm just going off at a tangent, but from what my understanding of the discussion is, should we as a global community of healthcare providers for traumatic brain injury have a common platform of agreed protocols which are available at every level where a patient is likely to present himself or herself? By that, I don't mean the little dispensary necessarily that's tucked away near a village, but certainly a county hospital, which is within a 50-kilometer range of that particular patient. Because the practices currently, certainly working in an LMIC region of sub-Saharan Africa, is that when a traumatic brain injury does arrive, everyone at that kind of primary care facility begins to wonder whether this patient should be shipped off to a higher level institution. And usually the criteria there is there a person either in critical care or in neurological surgery that is available to take care of this patient. And in the sub-Saharan African region, and I suspect in many, many LMIC regions in over 80% of the globe, that's not going to be feasible. So is my understanding correct in thinking that the discussion needs to be focused around the global community agreeing that at the first port of call, which is something like a county hospital, these basic criteria, these basic management protocols should be available? And that is intravenous fluids, making sure that the patient doesn't become hypotensive, oxygen provision, ensuring that the patient does not become hypoxic. And then, interestingly, you mentioned, where do we then go? Of course, the ABCDs are all given. You ensure that you've suctioned, etc., etc. At what level do we agree that the patient needs to be intubated? At what levels do we agree that the patient should then start getting hypertonic saline? And at what common institutions should we agree that the patient should become a candidate or considered to be a candidate, for example, a decompressive craniotomy? So that's not going to be available at most of the sites. But the first two, and perhaps the third, such as hypertonic saline, might be available at almost all county hospitals around the globe. So is that what we're sort of hoping to kind of get a consensus on? Just correct me and guide me there, but I think that's where we are headed. Thank you.
Thank you, Dr. Qureshi. I think you're bang on right. I think currently we think that the management of TBI starts at a neurosurgical center, and we need to move this starting point all the way back to the first contact. So in the ideal way, the place where the patient has first contact with a healthcare provider. Now, again, that's very ideal, but part of the consensus would be, where exactly do we put the starting line at? Is it a county hospital, a district hospital, a sub-district hospital, to emphasize that there is a chain of care? And yes, I think it would be great, especially, I think the timing is right because of the WHO resolution and now implementation on oxygen availability, and IV fluids, as you said, and hypertonic saline are very easily available. They're incredibly inexpensive, that we try to define a common protocol platform framework where TBI care begins not when somebody meets a surgeon, a neurosurgeon, but all the way at the simplest facility where they start getting oxygen and IV fluids. So I think you're absolutely right. That would be the intention, and we don't know what should be done. Hence the consensus, and having people from 60 different countries with about 270 specialists. I hope we can make some sort of a realistic consensus about it, and then of course it goes into, you know, how does one implement that? But yes, absolutely, I think that's the idea behind, is to generate some sort of a still weighed in evidence, a common platform, how we see TBI globally.
All right. Thank you so much. There is a question in the chat from Susan. Would this protocol mimic a similar structure as different levels of stroke centers?
It's a good question in terms of, you know, similar to stroke centers or trauma centers. Do we define level 1, level 2, level 3 as we do in the US? And I think that might be a little difficult if we are looking at different political, geographical, healthcare landscapes. I think it would be, in my personal opinion, and again, that's why we want to see consensus, is that it may be too much of trying to put a peg in a pre-specified hole. I think the emphasis should be that these processes must occur, and where they occur, I think, remains to be determined. Now, does that mean, I think the downside of designating centers is there are two sides. That one is it mandates them to provide the care, but on the other hand, it relieves the responsibility from the other care providers to provide things that would be beneficial to the patient in the interim, because then everybody, as we do now, is trying to transfer the patient. So I would wait for the opinion of all our colleagues to see which approach. My personal opinion, as I said, would be that it should be agnostic to location, and should remain a continuum of care.
All right, thank you. Thank you so much. Few last questions before we close up our meeting today. This is from Success Imok. Given the significant disparity in healthcare access and quality across different regions, how can global health organizations work to standardize and improve early diagnosis, treatment, and long-term rehabilitation for traumatic brain injuries, particularly in low and middle-income countries where resources may be limited?
I think that literally lies at the very fundamental motivation we have for this, because we know there is a need to do this. We know that if you don't get basic care, your survival is worsened. And we know that higher intensity of care, when the basic has not been delivered, really inflicts catastrophic health expenditure to somebody who could have had a significantly lower cost basic care to help improve their outcome. So how do we do this? And that's, I think, the million-dollar question, is to try and seek consensus from our colleagues across the world as to where do our commonalities lie. Are these binding to everybody? No, it's going to be a framework. And we want to stay away from saying these are the minimal standards, because we don't want it to be a sort of perception of this is a lower level of care. It is even more important than surgical intervention, but can be provided at a less resourced facility. And it is a continuum. So we don't want to say minimum standards, but we do want to come up with a way that effective treatment can be equitable. And by and large, a lot of the interventions that will dramatically reduce poor outcomes are actually relatively cheap. IV fluids and oxygen. It's the access, and I think that's where this is a good time with the WHO ramping up its implementation work on increasing oxygen capacity. I hope that sort of answers the question.
All right, thank you, everybody. Would like to introduce you to the upcoming webinar. Please join us on the next Thursday of November 21st for our next webinar featuring Dr. Paul Young, who will be speaking on building East African first dedicated neurosurgery hospital and the power of volunteerism. Again, thank you so much for joining us today. And yeah, I would like to thank Dr. Mangat for the nice talk and all the speakers that have contributed today, as well as the one that posed their question on the chat.